Well, thank you. I'm not sure how much of a debate this is going to be. I suspect Jean-François and I pretty much agree on the finding, but it'll be interesting to go through. So obviously everybody knows that COAPT was a randomized trial comparing the mitral clip in patients with secondary MR against optimal medical management. Let's see. So their primary endpoint was a reduction in recurrent hospitalizations for heart failure with secondary endpoints, composite of 30-day all-cause mortality, stroke, and MI, or surgery for device-related complications, 1 year all-cause mortality, and then a change in MR severity, 6-minute walk, quality of life, remodeling, a New York Heart Association class. And in 2017, I was asked to give a talk about what I predicted the results would be. And I predicted then that they would make their primary endpoint of a reduction in hospitalizations for heart failure. I said that their secondary endpoints, we knew the clip would reduce severity. We already knew that it led to reverse remodeling of the left ventricle, and I thought that New York Heart Association classification would improve. And the reason I said that was based a lot on these acute data from Purley et al. That looked at the effects of placing the clip on acute hemodynamics. And the clip reduced filling pressures and increased cardiac output. So guess what? I mean, those are the things we try to do with medical therapy. These were patients already treated with medical therapy. If the clip provided those kinds of changes in hemodynamics, I thought that it would reduce hospitalizations due to heart failure. I wasn't sure about quality of life and 6-minute walk, and the reason I questioned that were these data from the Cleveland Clinic that looked at patients with ischemic MR, CABG alone versus CABG with a mitral valve annuloplasty, and 2 years out there was really no difference in New York Heart Association late classes, and their conclusion had been that although CABG and mitral valve annuloplasty reduces postoperative MR and improves early symptoms compared with CABG alone, it does not improve long-term functional status or survival in patients with severe functional ischemic MR, Tommy Mihalovich and colleagues in 2007. And I said I would be surprised if they made their composite endpoint of 30-day all-cause mortality, et cetera, and 1 year all-cause mortality, because nobody had ever demonstrated that it worked. So these were from Steve Bowling's group, one of the first people to suggest that you could actually treat secondary MR, and there was no difference between restrictive annuloplasty and medical therapy. In this small randomized trial, which was not powered for a mortality difference by Fatucci and colleagues, there wasn't even a signal that surgical treatment of MR would reduce mortality. And then when you look at the CTS randomized trial, which the purpose was to compare mitral valve replacement with repair, but the reason I'm showing the slide is that 2 years out, the mortality was 20%, 10% per year, which was pretty much what it's always been in that 10 to 15% range. So my reason when I said that I didn't think that the clip would alter mortality was nobody had ever demonstrated that mitral valve repair, at least surgically, would alter mortality. And then there was this meta-analysis of almost 3,000 patients that also showed no benefit in survival and no improvement even in symptoms with mitral valve repair in secondary MR. I said, that's why we call it secondary MR. It's secondary to another cause, disease of the ventricle, and not treating that disease primarily, you wouldn't expect a change in mortality. And then the Mitra.fr trial comes out, and it sort of proved everything I said. There wasn't any difference. Jean-François will talk about this in a minute. But okay, and then of course comes COAPT, which was striking in the differences, where there was this huge difference in rehospitalization for heart failure, needed to treat only 1 in 3 patients, and an improvement for the first time, any device, in a randomized trial of mortality, needed to treat just 6 patients. And so, obviously, and we'll hear from him in a minute, why the differences? Well, they were different patients. Age was about the same. But the effective regurgitant orifice was much larger in COAPT. There was more MR, and the ventricles were smaller. Ejection fraction, which is a horrible tool, shouldn't be used in MR to begin with, but it is. What can I say? And so these were patients in COAPT with more severe MR, smaller ventricles, and there was a very aggressive stance taken by the screening group to make sure that patients were really treated to the absolute maximum with medical therapy. I had patients rejected because we had not treated them aggressively enough, because guideline-directed medical therapy works going back 32 years, to these data from Warner-Stevenson, looking at what really aggressive, and in this case a Swan-Ganz-directed medical therapy, reduced end diastolic volume and practically got rid of mitral regurgitation. So that if you really take aggressive medical therapy and after you're done, you still have severe MR, then I interpreted this to what I call tertiary MR. That is, there's so much secondary MR left that it no longer is a bystander. It is no longer a product of ventricular dysfunction, but rather is actually causing additional ventricular dysfunction by itself. And that tertiary MR then is a target for additional therapy, i.e. the mitral clip. Paul Grayburn interpreted those data slightly differently. And his idea is that it was a bad fit. The ventricles, for whatever reason, in COAPT didn't enlarge enough to accommodate the severe MR that was left over, leading, of course, to increased filling pressures and reduced cardiac output. I'm not sure that he and I actually talked about this at length. I think both concepts are kind of interesting. And then, so the question now is this the new gold standard for the treatment of secondary MR? And what would you do with this patient, a 60-year-old diabetic man with 3-vessel coronary disease and severe secondary MR? The FREEDOM trial says he should go to surgery for his coronary bypass, for his revascularization of his coronaries. But COAPT might say that, yeah, but should he get a surgical repair at the time of his coronary bypass surgery, or should we put a clip in first and then send him to surgery? I obviously have no idea the answer to my own question, but it's an interesting one to think about. Anyway, my views on COAPT. Thank you very much for your attention.
Thank you. Thank you, Blase. Now I'd like to invite Professor Obadia. Yeah, please.
Thank you for your invitation. Okay, excuse me. Okay, so I have to discuss the respective weight of those 2 studies published in the New England Journal of Medicine last year. And these are my conflicts. And 2 different studies, and you see 2 different results. I remember when I presented those results in Munich, it was a sad day. Everybody was crying in the assembly, and Abbott was close to suicide. While 1 month later, it was exactly an opposite ambience. With when Greg Stone presented his study, every other slide, people applauded in the assembly. So two different aspects, 2 different results, and we have to explain that. And it has already been said by Blase, and thank you for your comments. And I agree with you that the difference in the recruitment of the patient probably explain those different results. Actually, in Mitra.fr, we have less severe MR and more severe left ventricle, and this is probably the main explanation. In Mitra.fr, we probably recruited too late the patient, while in COAPT, the selection was more accurate. We also have to remind us that Mitra.fr is an academic study supported by the French Ministry of Health. You see that the publication of the protocol have been done in 2015, 3 years before the publication of the result, with absolutely no modification in the protocol. While for COAPT, this was completely different. Of course, the study was followed by the FDA, but they have changed the protocol all along the enrollment period, and at the end, they had to double the number of patients who had to be enrolled in the study. So the philosophy of those two studies were different. And if we compare the quality of and the expertise of the centers who were participating to the enrollment, you see that in COAPT, they had 3 patients in the rolling period, meaning they had to do at least 3 clips before there was a selection, the site was selected to enroll patients, while in Mitra.fr we had to enroll 5 patients. The device success was very similar in the 2 studies, and also the quality of the reduction. So the expertise of the 2 teams on both sides of the Atlantic was very similar. But if you look at the flowchart from Mitra.fr, you see that we had to exclude 32% of the patient, and in COAPT, they excluded 61% of the patient, mainly for the reason reported by Blase just before me, when he said when they had a patient that they wanted to take care to the quality of the medical treatment, and they refused to enroll patient if the medical treatment was not absolutely accurate. While in Mitra.fr, we didn't centralize the selection of the patient, and every center was responsible for the decision if the medical treatment was optimized. So maybe in Mitra.fr we were less severe on the selection of the patient. But if you look, this is one of the main critiques we can address against COAPT, because you see the bigger centers, which is Sinai, included 46 patients during 5 years, meaning 8 clips per year. So the biggest center in US include less than 1 clip per month. So the selection is very, very severe. So that today, I don't think that the patient who receive a clip worldwide are not so well selected. And if you look at the complication in both studies, we have the similar rate of complication, and we confirm in Mitra.fr and in COAPT the technique is very safe, the technique is efficient. You see the procedural success. These are the 3 randomized studies, Everest 2, Mitra.fr, COAPT. Everest it was the first one, 77%, but today the success rate after a clip is very high, over 90% in the 2 prospective randomized studies, but also in the biggest registry in Northern Europe. And if you look here, this is the baseline value, grade 4 and grade 3, and are discharged, so the clip is efficient, even if there is still recurrent MR after 1 year. The medical treatment was also efficient, but of course the clip was much better than the medical treatment. But no impact in Mitra.fr, no impact on our primary endpoint, all-cause death, and the first unplanned rehospitalization for heart failure. Moreover, if you look at the subgroup analysis in Mitra.fr, we only have one trend when the mitral regurgitation is severe, and this is probably start to accommodate the result of the 2 studies, while if you look at the subgroup analysis of COAPT, every subgroup is positive. So the results are really different, and the explanation has already been said. Probably the severity of the MRs and also the dilatation of the ventricle is the explanation. So probably this should be the conclusion, the easiest conclusion. Every study is important. We didn't look the same way to the secondary MRs, so the results are different. But now, since it is a debate, and I have also to address some questionable aspect of the result of COAPT. And for instance, it has been repeated that here, before the enrollment, the patients were very, very highly selected. The medical treatment was perfect, and the patient was supposed to be stable. How can you explain that just after the randomization, all of a sudden, the patient start to be hospitalized? And if you look here, you see that after 1 week, they already are more hospitalized in the control group. Meaning, at this time, the patient have not yet received the clip, and there is already a difference. This is the weakness of an open study, and probably the fact that the people knew that who groups they belong to influence the decision to rehospitalize or not. So this is probably a weak endpoint, and this was a primary endpoint of COAPT. But this is the most important slide in COAPT. It modifies the mortality, and we have to accept it. And this is a fantastic result, and we have to congratulate the team of COAPT to have been able to select accurately the patient, because this is the only paper in the literature who shows that treating the secondary MR has an impact on the follow-up of the patient. Maybe we could explain at least partially this difference, because if you look at the medical treatment in COAPT, there is a statistically significant difference at baseline. So the control group in COAPT was not as well treated as the Mitra clip group. And it was true at baseline, it was true during the follow-up, but you see the difference is not very high. But this may explain, at least partially, the difference in mortality, even if it cannot explain everything. But we have the feeling that the medical treatment, in COAPT, they didn't give the best chance to the medical treatment to be efficient. Here you see on the same slide the mortality of the control group of COAPT and Mitra.fr. So you see, we used to say that the selection was different, but when you put on the same slide, it's not evident. We have the feeling that it was more or less the same patient, because the control group of COAPT is very similar to the follow-up of the Mitra.fr patients. And this is also very impressive, because this is the only paper in the literature where you have the feeling that treating a secondary MR is forever. In any paper in the literature, the weakness of treating secondary MR is the recurrence of Mitra.fr. This is true for surgery, and very, very important. In the STEVENSON trial, it represents 32% after 1 year. And here, absolutely no. And moreover, if you look in COAPT, we still have patients with grade 1 or grade 2. We know that the clip is not perfect. And we also know by this paper, if you have a grade 2 regurgitation, we should have an impact on the mortality. Why this does not appear inside the COAPT result? There is some question in COAPT. And these are two slides which have been presented during the recent American College of Cardiology. And for instance, this is questionable. I don't understand those slides. For instance, you see the end diastolic and systolic diameter. This means 60 milliliters of ejection altogether. That is very easy, just simple mathematics. So, and here on the other slide, the regurgitation volume is 59. So this means that the stroke volume should be 1 milliliter. This doesn't make sense. There is something wrong somewhere. So you see that it's not easy. Of course, this is this paper, and proposed by Graben, the ejection fraction. You have to interpret the regurgitation surface according to the end diastolic volume. We also have to propose to add the ejection fraction in a 3D representation, and maybe this is an elegant way, but we probably need a new definition for secondary MR, a more integrative approach of all the parameters of the ventricle. And this is the conclusion. safety and efficacy, we agree they are very good with the clip. It's a safe technique. It's efficient on controlling the MR, not perfect, but efficient. But, and probably Mitra.fr included too late and too large, not enough selection. Probably COAPT, on the opposite, had a very narrow and very accurate selection. And today, the Mitra clip has to be, it's a good and important message for our community. It's important to treat severe regurgitation when it is not too late. And this is work for the heart team, and the clip is not a solution for any patient. I think a mitral valve team should offer our patient from sternotomy to percutaneous replacement or clip or whatever, or mini-invasive surgery. And this is a discussion for the heart team, and this is probably the most important message. Thank you for attention.
That was lovely presentations, both of you. Have a seat and we can talk. Aurania, do you want to take us through a little talk? We have about 5 minutes, just to stay on time.
So we heard both of you actually saying about the COAPT. So I would like to ask you, so I'm a 75-year-old, and I have moderate to severe MR, and I have two-vessel coronary artery disease. My LAD is 85%, and my RCA is 80%. So what do you guys recommend? And I have a very severe COPD. My FEV1 is 25%. So what do you guys are going to do? I'm in your office, and you really have to tell me something.
Well, so I don't think any surgeon is going to want to operate on a patient with an FEV1 of 25%. And I don't know that you would get much improvement. And also, it'd be very hard to know whether your dyspnea is due to the mitral regurgitation or the COPD, which I suspect the COPD is dominant. I think that patient probably gets 2 stents, and if the MR is only moderate, I'd leave it alone. I wouldn't touch it. I would treat you with medical therapy and 2 stents.
Okay, 6 months down the line, I still have shortness of breath, and I'm really symptomatic.
But you only have an FEV1 of 25%, and I can't make your lungs any better.
What do you think?
Well, I think you also have to do a stress echo and to try to see if there is a contractile reserve. There was, with Mitra.fr and COAPT, some parameters have been taken into account, but we don't have to forget what we have learned after 30 years of surgery. And we have published with Robert Dion, with David Adams, with Steve Bowling, some parameters who are highly predictive of the success rate after a mitral valve repair. Of course, it is a surgical valve repair, but we have some data. We know the end diastolic diameter. We know the angle between the posterior leaflet and the annulus. We know the tenting area. So there are many details we have to be taken into account before you take the decision. And altogether, this has to be discussed in a heart team, I think. And this is the best way to give every patient the best chance. But I agree. For the first step is to give the medical treatment the chance to be positive, and I would have done, as you said, treat medical treatment first, and then you can discuss after.
Do we over or underuse the mitral clip, in your view?
Yeah. We use a few clip in my institution.
I suspect that maybe 1 in 10 patients with secondary MR is a clip candidate. First, as you say, we can't wait. If we've waited too late, we probably are not going to get, and if the ventricle is huge. And this 130 end diastolic volume index has actually come up in other studies as maybe a cut point where the ventricle is not going to recover. And then after you treat them, I believe that these patients should have a BUN of 30 and a blood pressure of 90. That you've really beat the hell out of them with medical therapy. And then if they still have severe MR...
People say surgeons are mean.
and then maybe, but I think unfortunately many people will overstate the COAPT case and want to use a clip on everybody. And as you say, I think it's a very rare patient that's the 2 studies, in my view, work beautifully together to tell us whom we should be treating. And there are not that many out there that qualify.
Jean-François?
No, I agree.
Anything else? Finish? Okay. Great. Well, thank you very much, both of you. A big round of applause for our debaters.